Hi, everyone. Welcome back. We're going to get to the second part of the talk here with Dr. Johnson. And remember, please put your questions in the chat if you have any more that come up. Thanks, Jen.
Thank you. Okay, let's get right back into it. Oops. Oh, there we go. Okay, no disclosures for this part either. Okay, we're just gonna pick up where we left off. We're on to case number 3 now. So this is a 47-year-old man with a T4 spinal cord injury complicated by paraplegia and a neurogenic bladder. He's got a suprapubic catheter in place and has recurrent UTIs. And I'm just gonna throw in this caveat right here that I'm not broadly gonna be covering everything about UTIs. I know that there's some other UTI information elsewhere in the course. This is really a specific antibiotic targeted question here. So for this patient, he gets admitted with fever and hypotension, and he responds well to intravenous fluids, but he's noted to have had a prior history of Pseudomonas UTI and Pseudomonas bacteremia. So which antibiotics might we think would be appropriate for an initial empiric regimen for this particular patient? So it turns out for this patient, we have actually fairly limited list of antibiotics that could treat Pseudomonas that just even have the potential of activity depending on, and then we'd have to narrow down based on a history of resistance that for this particular patient in the past. So we really only have essentially one oral antibiotic option. So we have these 2 oral fluoroquinolones, ciprofloxacin and levofloxacin, that both have activity against Pseudomonas, but they track as essentially the same drug. So if one is intermediate or resistant, then the other one is going to be as well. So I really just think about it as one oral agent to treat Pseudomonas. So if this patient has Pseudomonas that is resistant to either or both of these antibiotics, then there are no oral antibiotic options for this patient, for treatment of this patient. In terms of our intravenous options, we have our intravenous anti-pseudomonal cephalosporins, which is ceftazidime and cefepime. So the things to know about these agents is that depending on your antibiogram, so certainly at our institution, they're effective at around 85 to 90% of the time for Pseudomonas in all comers here. And they have a very low toxicity. There are these rare reports, and there are multiple studies now looking at different sides of this coin about the potential for encephalopathy with cefepime, which I'll just summarize to say that it is a rare consequence and seems to be primarily in patients who are otherwise prone to it, who are either elderly, have some sort of underlying neurocognitive disorder, or who have a history of alcohol use disorder with recent use or benzodiazepines. So it's not a contraindication for any or all patients to receive cefepime. That seems to have gotten away from us a little bit at our institution, where there's a kind of a fear of this complication, which is really actually quite rare. The other difference to note, actually, more importantly, between these 2 agents is that their spectrum of activity is actually very different. So ceftazidime is sort of like, I don't know how much this makes sense, but sort of like the opposite of vancomycin. So it is a narrow antibiotic that only treats gram-negative organisms, as opposed to vancomycin, which only treats gram-positive organisms. Ceftazidime does treat some resistant gram-negatives, including Pseudomonas, and some that might be resistant to some other beta-lactams, but it only treats gram-negatives. Cefepime is a more broad antibiotic. It treats resistant gram-negatives, some that are resistant even to ceftazidime, and it treats some gram-positive organisms such as streptococci, some staph MSSA, enterococci. So it has much more broad activity. Okay, so that's a difference to note between those. And then piperacillin, or piperacillin, most commonly given as piperacillin tazobactam, which is our anti-pseudomonal penicillin, which is effective and has been associated with some potential for renal toxicity, especially when given with other agents. Although again, that is pretty specific to dosing and to patients who are already at risk for developing renal toxicity. It is an even more broad antibiotic. So similar to cefepime, it treats both gram-negatives, including some resistant gram-negatives, gram-positives, including MSSA and enterococci and strep, and it treats more anaerobes. It's more broadly effective against lower GI anaerobes, not all but many, as compared with cefepime. So you're kind of going down the scale here, getting more and more broad in terms of activity. Then those, and the reason I put those in red is that those are our three most commonly used agents for treatment of patients with a risk or a known infection with Pseudomonas here at our hospital, because of the generally the very high efficacy and fairly low toxicity with these agents. Your other potential options would be aztreonam, which is a monobactam, sort of vaguely related to the carbapenems, but slightly different. There is some resistance out there in the community, and it used to be used primarily for patients with beta-lactam allergies because there's a much lower risk of cross-reactivity. But now we have lots of other ways of mediating that with test doses and a better understanding of those allergy pathways. So we use it pretty infrequently at this point. Then we have our two anti-pseudomonal carbapenems, imipenem and meropenem. In our hospital, even though those are more broadly active against some resistant enteric gram-negatives, they actually have a lower level of susceptibility for Pseudomonas in our hospital. We get resistance to these sooner than resistance to these other agents typically. It's not drastically different, but it is somewhat different. So they are more broad for some gram-negatives, but not more broad for Pseudomonas. And I think this is where things get really tricky with the gram-negatives. There's just so many different organisms and different pathways to resistance that there's not necessarily one drug that you might reach for to sort of like treat everything when you're worried about a patient. Then we have the aminoglycosides, amikacin, tobramycin, and gentamicin. There has been this idea in the past about using agents for synergy. This really effectively has been kind of dispelled. We used to use this in a couple situations in patients with some endocarditis with certain organisms. We do that much less frequently now because we know it carries a higher risk of toxicity with probably not a lot of benefit. And we used to use them in combination for patients, especially with cystic fibrosis with pneumonia. Haven't found a lot of efficacy in recent years with that. So the idea of double coverage of adding this on if a patient is critically ill and might have a really resistant organism, I think is still one that is potentially useful in some situations. But if there are less toxic alternatives, that would be better. And we're going to talk about the toxicities of aminoglycosides shortly. And then we have the polymyxins, colistin and polymyxin B, which we'll talk about in a moment. And then these newer agents, which we'll talk about further in a moment. So we talked already about cefazolin during the first talk. I'll just mention ceftriaxone, and I just want to actually put in a plug for ceftriaxone because I find that I recommend it a lot as an infectious disease doctor in situations where it hasn't actually been used. People are often reaching for these anti-pseudomonal agents, even in situations where a patient really is unlikely to have a Pseudomonas infection, or potentially thinking about cefazolin or vancomycin or other things. But ceftriaxone is a great antibiotic. It's dosed, we usually use a dose of 2 grams IV Q-day, which is sort of like the max tolerable dose for any severe infection. And if you're in the hospital with your infection, it's probably severe. And it doesn't need to be dose adjusted for renal function. So that's fabulous. And it's really pretty actually broad and tremendously effective for severe strep infections, which is a lot of patients. For most community-acquired gram-negative infections, great for a lot of all the oral flora and a lot of bowel flora. And it's probably pretty good for MSSA. It's not the drug of choice for any severe MSSA infections, but if there's some MSSA around in whatever you're treating, it's probably pretty good for that. We talked a little bit already about ceftazidime and cefepime. And I already mentioned this rare complication of encephalopathy, which I just don't want people to broadly assume that that's a problem. I think there's really, it's hard for me to think of any patient that I would just not even give cefepime to at all because of the risk of encephalopathy. In almost every situation, if you need to use it and that's the best drug because you need a broad antibiotic that treats Pseudomonas, whereas ceftazidime, again, is a more narrow antibiotic that treats Pseudomonas, then go ahead and use it. And if the patient develops encephalopathy, you can take the drug away. And it's almost in almost every case. I've never had a case that was not reversible. That was a double negative. It's always reversible with vanishingly rare exceptions. Okay, so what are we going to do for this patient? So this patient, let's say he comes in. Now remember, we're worried that he's got pyelonephritis, maybe was a little septic when he came in. He had some hypotension that was fortunately fluid responsive. So we're not thinking about, some kind of little cystitis. We're thinking that this is a bigger deal infection. Let's say he grew this organism, Pseudomonas, again, as he does, and it was resistant only to the fluoroquinolones and meropenem, this anti-pseudomonal carbapenem. We could just treat him with ceftazidime. That's narrow to treat just the Pseudomonas that he has, and he could do really well. That's how it could have happened. But remember, we have experience from the first talk. We know real life is different. So here's what really happened. Instead, he grew this Pseudomonas, which is really much less friendly looking. It's essentially read as being susceptible only to aminoglycosides, amikacin, gentamicin, tobramycin, and polymyxin. Colistin is the brand name, or colistimethate. What are we going to do now? Yikes. Okay, so do we want to give him an aminoglycoside? Here's how we think about these. Here's those drugs. So on the pro side, they are bactericidal. They maybe have this synergy with beta-lactams like enterococci and strep in these bloodstream infections, although we're getting a little less convinced of that. They're really broadly active against many gram-negatives, including Pseudomonas, and we maintain a really high level of susceptibility, as you saw with that patient's culture results. But there are some problems. So there is a pretty high degree of nephrotoxicity and ototoxicity. And what's really tricky about it is that there is this really narrow therapeutic window that you have to hit with these drugs. You need to really understand the patient's renal function, and you're going to give them a weight-based dose, and then you're going to be following levels. You need a lot of support from pharmacy. You need a lot of reassurance that their renal function is not rapidly changing, because that is going to make it really easy for the dose to fall outside of this narrow therapeutic window, where you're going to fall too low and the patient's not getting enough drug and to respond to the antibiotic and is going to get sicker. And usually we're using this when patients are really sick, so that's not a great option. Or you're going to fall too high, and then the patient's going to develop toxicity like nephrotoxicity or ototoxicity. Now, since we use these drugs very infrequently at this point, it's uncommon, because we have so many less toxic alternatives. But just to give you a landscape of this, for adult patients, when we fall outside of that window and the dose is too high, there are patients out there who are on dialysis because of aminoglycoside nephrotoxicity for the rest of their lives. Patients with deafness, aminoglycoside-associated deafness. This does not seem to be a phenomenon in young patients. So this is actually IV aminoglycosides are still a part of the routine guidelines for treatment of some obstetrical infections. Also not seem to be an issue for pediatric exposure or even in utero exposure. But for our older adult patients or patients with other comorbidities, it's very easy to fall outside that window. So that's why we end up reaching almost universally for other agents when we can. Okay. So how are we going to find these other agents? Because there were no other options on the susceptibility result. Well, we might have to ask for additional susceptibility testing, and we might get this. But what is this? So I'm guessing at this point, all of you probably have encountered these two antibiotics, or at least the names of them, ceftazidime avibactam and ceftolozane tazobactam. But these are a part of a growing number of new beta-lactam antibiotics that are largely beta-lactam with beta-lactamase combinations that are in some way new. Either the beta-lactam is a new derivation that's combined with an existing beta-lactamase, or vice versa. And so this is actually a few of them. We also have imipenem relebactam, and there's a few more that are coming online that will but the themes are the same, which is what I will kind of go over here. I think the things to know about these antibiotics broadly, first of all, is that they all have subtle differences. And so it gets really important when you have either a known broadly resistant gram-negative organism, or you think that the patient is at high risk for that based on their history and what's going on with them. It's really important to try to communicate together with others in your hospital about this. So if you have an infectious disease specialist, then that's helpful. If you have somebody in the micro lab you can talk to, we're always talking to the micro lab when these cases come up. And we also have pharmacists that we talk to. We have infectious disease specialist pharmacists, but any pharmacist would be helpful and will know how to reach out to infectious disease specialist if needed, because it helps us understand what's a good empiric choice, what susceptibility testing would make sense in these specific cases. And these are unfortunately growing, and this is where we're headed, is in more and more complicated gram-negative resistance. So a couple of specifics that might be helpful about these antibiotics. I think these are probably the first two you might be thinking about reaching for if you have a resistant organism. Ceftolozane tazobactam is probably the first drug that I often reach for a case of multi-drug resistant Pseudomonas aeruginosa. Okay, so this is a good one to have in your pocket as something you might reach for empirically for Pseudomonas while you're waiting susceptibility testing. Ceftazidime avibactam also potentially. This we might use also for some carbapenem-resistant Enterobacteriaceae, so enteric gram-negatives that are carbapenem resistant, such as Enterobacter or E. coli. And then meropenem vaborbactam, also active against some of these resistant enterics, E. coli, Enterobacter, Klebsiella, those type of organisms, does not really help improve efficacy against Pseudomonas. Okay, so where you can see we're kind of delineating the Pseudomonas, which is a non-enteric gram-negative, from the enteric gram-negatives, because they are phenotypically a little bit different in terms of the antibiotics we might use. But again, broad generalizations is really difficult with once we get to this level. And this is why, so we are not going to go through this line by line, but this is just to help you kind of get a framework that we sometimes people throw around this abbreviation a lot, this ESBL, extended spectrum beta lactamase. I think it has become something that people sometimes use as shorthand for just like a resistant organism, but actually this is supposed to denote a really specific mechanism of antibiotic resistance. So if you want to use a shorthand for a broad antibiotic resistance, especially for gram-negatives, I usually use the MDR, so multi-drug resistant, because that actually does not denote a specific pathway. It just denotes that it's resistant to a number of different antibiotics. And it's important because all these different pathways are subtly different, and may lead to a different panel of antibiotics that may be an option for your specific patient. And there is just no way to keep track of all these. Also, our understanding of these is evolving over time. And so guidelines about how to interpret susceptibility and what that means for a patient actually are adjusted from year to year. So even if you understand and you have it all memorized for 1 year, things will change. So this is really a whole area of hyper specialization at this point. Some drugs that we don't use commonly for resistant gram-negatives, and I just want to explain why, are these. So we have the polymyxin class, which includes polymyxin B, which can be given systemically, intravenously, or can be given topically. So you've probably given polymyxin B or actually used polymyxin B as a part of a combination antibiotic ointment, such as Neosporin brand previously. So these agents, these polymyxins, actually are useful topically, otic applications. They're pretty broad treatment of gram-negatives. They act essentially like detergents. So you can sort of understand why when we give them systemically, there's a higher risk of development of renal dysfunction. And colistamethate or colistin, similarly, it has a similar mechanism of activity, maybe a slightly higher risk of nephrotoxicity. But what we've learned in recent years is that these agents, unfortunately, don't have, even though in vitro they might have some activity against some of these multi-drug resistant organisms, their in vivo activity is not as great as we would expect, and oftentimes doesn't overcome the potential of toxicity with them as compared with some of these other newer agents, meaning that they're not better at hitting that sweet spot of activity versus toxicity than, for example, ceftazidime avibactam or ceftolozane tazobactam. Those newer agents are, as you can imagine, quite expensive. So you'll definitely hear from your hospital if you're keeping a patient on ceftazidime avibactam for a long time, but sometimes that's just what is called for. And then the last drug to mention here is tigecycline. We mentioned this in the first talk as a drug that treats MRSA, which it does. It is an incredibly broad antibiotic. It also treats many gram negatives, including some resistant gram negatives. It also treats VRE. And there's been some questionable data looking at it having potential activity even against C. diff. But there are a couple caveats. We talked already about the black box warning in the case of sepsis, that it's because of the way that the drug actually rapidly distributes into tissues and is not maintained intravascularly. It's not helpful for patients with sepsis, and there were actually a number of deaths after it was first approved where it had been used in sepsis. It also has no activity because it's in the sort of tetracycline family. It's a glycylcycline. It's a minocycline derivative. All those agents actually have no activity against Pseudomonas or Proteus. And so there are some holes in coverage. So it can't just be used as a, treats everything antibiotic for a patient who comes in sick. Practically speaking, we use this antibiotic only when the patient has resistance to everything else or allergy to everything else, or in some odd cases, the patients have mycobacterial infection. And we have some other options even to replace tigecycline in some situations. Which would be eravacycline, which is available intravenously since 2018, which is perhaps a little better tolerated than tigecycline. And then omadacycline, which is sort of the big deal because it has some similar spectrum of activity, but is available also orally. And then cefiderocol. So this was FDA approved in 2019. Similar to a lot of these agents, the FDA approval, a lot of these newer agents, the FDA approval was for a relatively benign type of infection that we actually don't commonly use this antibiotic for. It was approved for the treatment of complicated urinary tract infections. But what we really use it for is for treatment of these highly drug-resistant gram-negative infections. So with some Pseudomonas and some highly drug-resistant gram-negative Enterobacteriaceae or Staphylococcus or Burkholderia. It's a funny antibiotic. It has this really funny way of actually attaching to the bacteria and kind of getting penetrated into the bacteria. And so it's, which also the reason just to be aware of that is that it means, practically speaking, it means that it's a little bit difficult for susceptibility testing in some settings. So if you are thinking about this agent and you talk to your microlab and they say like, oh, well, we can't get susceptibility testing or something like that, that's why it is. It's because it has this odd mechanism. It is important for all these new agents, even though they're new and even though your patient may never have been exposed, there is still the possibility that they already have resistance to these agents. And so it is important to try to get resistance testing or susceptibility testing, however you want to phrase it, when you're using these new agents, even if the patient's never seen them before. Okay. We're going to shift away from these highly resistant gram-negatives and go to another case. So this is case 4. This is GR. This is a 52-year-old man who has a prior history of diverticulitis, who's now being admitted with a sudden onset of left lower quadrant abdominal pain and fever. He's hemodynamically stable, though. So in this setting, if we're thinking about whether or not he needs antibiotics, with the caveat that in uncomplicated diverticulitis, he may or may not need any antibiotics at all. But let's say that he seems sick enough and he's being admitted and we feel that antibiotics would be warranted. What would be a good initial antibiotic regimen? And once again, similar to how I mentioned in the first case that we talked about this, I'm going to say that there's actually many different options here, many different right answers, and nobody should fault you for picking one or the other of any of these or potentially many others. If I kind of drill down the case, distill down the case to what we're actually trying to treat, we're trying to treat a patient who has essentially sort of community bowel flora without a lot of known antibiotic exposure and without any known immunodeficiency or prior history of resistant organisms. So there's many different ways to treat community non-resistant bowel flora. Here are some options. You could use Sulbactam as a single agent. You could use ceftriaxone with metronidazole combination therapy. You could use cefotaxime alone. You could use a fluoroquinolone with the caveat that there are some toxicities and drug-drug interactions that may actually. We at our institution we try to limit fluoroquinolone use to when it's when there are not other better options. So I would probably steer away from this, but it's not wrong. And then if the patient if it was a different situation where the patient had a history of immune deficiency or a lot of antibiotic exposure, you could think about actually using one of these more broad agents that empirically treats for Pseudomonas, or ertapenem, which does not treat Pseudomonas. It is the carbapenem that does not have activity against Pseudomonas, but it essentially treats all the other bowel flora plus resistant enteric gram-negative organisms. So like a multi-drug resistant or ESBL specifically to that pathway, E. coli, for example, or Klebsiella, all would be treated with. So those are some options. And you notice that in several of these options, we had included empiric treatment for anaerobes. And the reason is that we're thinking about a GI enteric source of infection for this particular patient. And so we know that even before we actually get any culture data, we need to think about the possibility of anaerobic bacteria being present. And treat empirically for that. If we were going to get a culture, this is sort of broadly applicable, not necessarily quite specific to this case, but they do, in order to actually find anaerobes in a source of infection, it requires a special culture collection into a special type of culture media and a special culture growth environment in the microbiology lab. It's very finicky, it requires a lot of expertise and a lot of labor and hours, and which results in them being difficult to culture, and they take a long time to grow. So even under all of the best conditions, if we get a culture from, say, an abscess and everything is done exactly correctly, we might hear about the strep and the E. coli in the abscess within the first 48 hours, but we might not hear about the anaerobes that were there until 5 to 7 days later, and that can be a huge problem if we didn't already think about needing to treat empirically for them. So it's important to have a high clinical suspicion for an anaerobic infection when you suspect a GI source. The one little note that I want to make here is that anti-anaerobe therapy is not needed for most episodes of aspiration pneumonia. There seems to be an understanding around with many people that if you've aspirated, or if your patient has had an aspiration event that you're treating for a possible aspiration pneumonia, that you might need to add metronidazole. That is not true. Okay, so two things about that. One is that actually most episodes of acute aspiration don't actually necessarily result in bacterial pneumonia. So oftentimes they either need no antibiotic at all, or if you gave one dose of antibiotic overnight and the patient's doing fine the next day, you can just stop antibiotics. It's okay. okay. The second is that even if you suspect that the patient needs antibiotic, either because we got to them late after their episode of aspiration, or they were very tenuous, or it really looks like there's something going on and persistent on imaging or clinically, what they would have aspirated, even if there's some, upper GI organisms and oral flora, those are all treated by the same antibiotics that you would use to treat community-acquired or even a hospital-acquired pneumonia anyway, without any addition of a special agent to treat anaerobes. So the oral and upper GI anaerobes are all treated with most beta-lactams. For example, ceftriaxone will treat essentially everything in the mouth, including the oral anaerobes. And the anaerobic organisms really aren't that capable of setting up an abscess or a persistent infection all on their own. They typically require some help, some support from the aerobic bacteria. So if you kill the aerobic bacteria, it sort of prevents the development of an anaerobic lung infection. So for all those reasons, you don't need metronidazole or any specific anti-anaerobe therapy for an aspiration pneumonia. And the reason you don't want to add it unnecessarily is that, of course, we never want to give patient an antibiotic they don't need, but especially with anaerobe therapy, because anaerobes take a really long time to grow, not just in the lab, but also in your body. And so if you give patients even 1 or 2 doses of metronidazole, it really kills off most of the anaerobic flora in their gut pretty quickly, and then it will take them a long time to grow that back. So you're really disrupting their microbiome to a much more significant degree than treatment with another antibiotic that does not include a broad anaerobic activity. Okay, I think I've beat that plenty. And we still have another slide about anaerobes. So we think about them. There is this idea about thinking about anaerobes above and below the diaphragm as being different. I mentioned that the oral anaerobes, and I've listed some names of them here, are all treated with, the beta-lactams that we use for pneumonia. They're also all treated with just straight penicillin for the most part. Clindamycin is fine for most of those, most beta-lactams. Certainly metronidazole will treat them. It's just way overly broad for what you need in terms of anaerobic activity. Metronidazole treats essentially only only anaerobes, but it treats all anaerobes. So gram-positive anaerobes, gram-negative anaerobes, like all of them, very, very effectively. And then the abdominal, so the lower GI anaerobes, some of those may be penicillin resistant. Bacteroides species is the one we worry about the most. Most of these combination antibiotics with beta-lactamase inhibitors like amsulbactam and piptazo and carbapenems will include activity against Bacteroides. The best activity will be with metronidazole. So if you have a patient with a persistent GI source, like they've got a perforation that cannot be remedied, they cannot go to the OR, and you're worried that they're going to get, or they've already gotten a bloodstream infection with Bacteroides, then metronidazole is your treatment of choice for that, in combination with whatever else you want to use for their other bowel flora. And then just a couple of other quick notes about comparing these two antibiotics. Clindamycin, they both have excellent oral bioavailability. You don't need to use these intravenously, either of them, if the patient is absorbing antibiotics in their gut. The clindamycin, I think there was this idea that it treats oral anaerobes and gram-positive bacteria perfectly. But I think the caveat, which is in the antibiotic myth paper, that I just want to make sure that people keep in mind, is that the gram-positives in the mouth, in the oral cavity, including strep and Staph aureus, actually have rising resistance to clindamycin, not so much the anaerobes, but those others. And so it's no longer a reliable empiric agent. So your patient who has a beta-lactam allergy, we no longer would just say, oh, just use clindamycin instead of cefazolin or something for their peri-op prophylaxis. It doesn't have enough breadth of activity against some of these gram-positive organisms. So if your patient has a beta-lactam allergy and you're looking to treat something on the skin because they're going to have a C-section, for example, then we typically would reach for vancomycin instead, where previously we might have said clindamycin. If they have just an oral infection in the mouth, then we might try to see if they could use a cephalosporin, or if they just have a penicillin allergy, or clindamycin with careful monitoring to make sure that they don't develop a gram-positive infection, or a fluoroquinolone if you really have to. And then this is an antibiotic that does carry a risk of C. diff, like most or all antibiotics. It's a little bit higher potentially than some, although there are plenty of antibiotics with really high risk of subsequent C. diff. I would include the fluoroquinolones in that for sure, and then even many of the broad beta-lactams as well. But it has a lot of other activities similar to metronidazole, where we use it actually for antiparasitic effects. So lots of these kind of other more interesting, unique infections that are less commonly seen. Okay, let's take a break from talking about anaerobes. So let's see what happened with this patient. So this is our patient who came in with history of diverticulitis with these symptoms, pretty acute symptoms. And in his case, he did actually have positive blood culture. So he had a gram-negative bacteremia associated with this infection. It was susceptible to ceftriaxone, found to be that immediately. So he was treated with ceftriaxone and metronidazole and had resolution of bacteremia. On his imaging, it showed a small fluid collection, so a small abscess adjacent to the sigmoid bowel with some inflammation, but no obvious ongoing bowel leak. And he was able to undergo a percutaneous aspiration by IR, and the culture actually also grew that pan-susceptible E. coli. So he got better, and now he's getting ready for discharge. So how long does this patient need to be on antibiotics? So he had a bloodstream infection with just a 1 day of bacteremia, and he had percutaneous sampling of the abscess. So this is this paper called for this trial called the Stop It trial, and we were a clinical site for this study. And so we reference it pretty frequently here, actually. There are many different hospitals that were involved, 23 hospitals in the US and Canada, looking at how long do we need to actually keep patients on antibiotics if they've been treated for an intra-abdominal site of infection. And so there were over 500 patients. And I think if you look at the criteria for the study, you can see that already there's a little bit of overlap here. There's a little bit of suggestion that there's going to be an issue here. So you have, it's a randomized controlled trial, but in the standard of care arm of the study, patients receive typically between 2 and 10 days of antibiotics, whereas the intervention arm was 4 days of antibiotics. So already there's a little bit of overlap, but I think on the positive side, you can see that patients in the study had a variety of different sites of infection, a variety of different comorbidities, and a variety of different mechanism by which source control was reached, either by IR procedure, by surgical resection, or just surgical drainage. And they look to see, does it really make a difference if we get source control? Does it really make a difference whether we treat them with 4 days of antibiotics or treat them with however long the primary team wanted to treat them with antibiotics, which ended up being between 2 and 10 days. And they saw no difference between the two groups. Caveat again to this is that there was around 18% non-adherence to the protocol. So there is a lack of statistical power there to ensure real equivalence. However, roughly speaking, this suggests that actually just a short course of 4 days of antibiotics should be appropriate in most situations like this. Now, this is not necessarily generalizable to a patient who has prolonged and severe immunosuppression with a prolonged infection before surgical source control, or who's unable to get source control and has a persistent abscess, or who has persistent bacteremia or bloodstream infection before source control. There's lots of different ways that you can say that, more complications would not actually make this data applicable, but there are also lots of patients who would fit into this criteria that where you could think, okay, just 4 days of antibiotics should be plenty for this patient. And this sort of goes along with this trend that we've seen in recent data where we're starting to understand that in many situations, we have been giving these long courses of antibiotics just because of sort of culture and sort of our sort of traditions, but actually we really don't need to. And so these are just a couple of examples where we have shown that giving shorter course therapy of antibiotics. So in this situation, patients who have bloodstream infection related to biliary tract infection, or in patients who have community-acquired gram-negative bacteremia from a variety of sources. A lot of them are urinary sources. And in both of those, we learned that actually treating for a total of 7 days or even less may be fine for most patients. So we're starting to understand this about a lot of different clinical situations. And I'll say that the other thing to think about for patients that you're trying to give less IV antibiotics to is even if you're not necessarily totally comfortable with taking away their antibiotic entirely after 4 days or something because they had a bloodstream infection. You want to get all the way to 7 days or something, but they're going to go home and you don't want to put in a PICC line for 3 more days, which is a great goal to not put in a PICC line. Then you want to think about what antibiotics have good oral bioavailability that I could actually use to continue treatment for this patient. And I think people have in their mind, usually the first 2 people we'll mention is linezolid and levofloxacin as antibiotics that have great bioavailability, and that's definitely true. But it's actually true of all of these antibiotics. All of these antibiotics have roughly or pretty close to 100% oral bioavailability. So we have a lot of different options for many clinical scenarios. The beta-lactams are a little bit more variable. So on average, we do better than I think most people think. We probably get around 75%, but they're a lot more finicky, I will say. There are things that we know that affect their bioavailability, like taking with or without around the time of food. But there are also factors that we don't always understand where patients seem to absorb more or not enough antibiotic when we're using oral beta-lactams. And so if there's an issue and someone's not doing well on an oral beta-lactam, then thinking about a different drug with better bioavailability or switching to an intravenous agent might be appropriate. Okay, and are we I think this is our last case. This is a case 5. This is a 50-year-old woman. That is an accurate age. This is a patient that I saw. She had been on IVF for many, many years. This is actually was her first pregnancy at age 50, who presented at 36 weeks pregnant. And she came in with fevers, severe headache, malaise, low platelets, and elevated transaminases. So this is terrifying. I'm sure even for those of you who are not practicing as obstetricians, I think everybody is aware that this raises a lot of concerns late in pregnancy, all of these findings. But very fortunately, she also had this. And so we practice in New England. And so this is a pretty pathognomonic exam. This is actually her exam. So she had this finding in her popliteal fossa, sort of like textbook. And she actually had multiple other lesions once we went around and looked, these sort of macular lesions. And so this is disseminated Lyme. And so fortunately, that's actually the cause of all of her symptoms. And it's not a pregnancy-related complication. And this is the best possible outcome. This is treatable with antibiotics, really not associated with complications to the fetus that we're really aware of, and should resolve with appropriate antibiotics. So the antibiotic that we typically use for most Lyme infections is doxycycline within the tetracycline group. There is an antibiotic myth, again in purple, with guidance to avoid doxycycline in pediatric patients and pregnant women. That turns out was based largely on data with tetracycline in the past, which is the oldest drug in class, and we actually don't use at all anymore because of known difficult dosing. It's dosed 4 to 5 times a day. and lots of association with different toxicities that we really don't see with doxycycline. So recent evidence actually supports the safety of doxycycline for children and pregnant women. I'll just tell you, in this particular case, with this patient, she was treated with IV ceftriaxone inpatient initially because she was, people were so worried about her in late pregnancy, and she was feeling quite ill. And she ended up transitioning actually to oral ceftriaxone initially because although this myth has been dispelled, everyone's not quite at the same comfort level with that at this point. But I think doxycycline would have been fine for her as well. So we use doxycycline a lot for treatment of atypical respiratory pathogens, with the exception of Legionella, which it does not treat. You really need azithromycin or a fluoroquinolone for Legionella. Treatment of Staph aureus for community-acquired, and then treatment of chlamydia or as a second-line therapy for syphilis in patients that can't get penicillin or can't get penicillin yet. And then treatment of lots of other spirochetal or rickettsial infections. Minocycline is an interesting antibiotic. So it has a spectrum of activity that's similar to doxy, but with additional activity against some resistant gram-negatives. And it actually, for some organisms, it can have better efficacy against Staph aureus. So some Staph aureus isolates can be resistant to doxycycline and still susceptible to minocycline. And it tends to be better tolerated in terms of the GI side effects, but it has a bunch more kind of weird toxicities, especially over a long period of time. Patients get a leukocytoclastic vasculitis associated with it. Their skin can turn blue if they've been taking it for long enough. And then there's some other autoimmune kind of funny things if people take it for long enough. But for short courses, it's generally okay. And then there's the macrolides. So similar to the tetracycline class, the first drug in class we really don't use anymore, which is erythromycin in this class. It because it has such bad GI effects, it's actually used as a gut motility, or was until fairly recently, as a gut motility agent because of its GI toxicity. But we don't really need it for efficacy anymore because we have azithromycin or clarithromycin. And I just want to focus really right here. Gosh, I should have put this in red at this point, on the strep resistance to azithromycin, because this still comes up with sort of frightening frequency. I just want to make sure that everyone knows that azithromycin is not the drug of choice for any clinical scenario where you think there might be a strep infection. And that's true both for beta hemolytic streps, like group A strep, so strep pharyngitis. Azithromycin, I would never assume that will be effective because we have rising resistance amongst group A strep isolates, and or strep pneumoniae. So for someone who has like a lobar pneumonia that you're trying to treat outpatient, I would never give them azithromycin as a single agent, okay? Or discharge them to home with just azithromycin if we're worried about pneumonia that could involve strep pneumoniae. So they really need a beta-lactam for that. So, amoxicillin, your oral cephalosporin, as long as they've already had a little bit of IV, that would be reasonable. And then clarithromycin is the other drug in class. We use that primarily actually for these atypical infections like mycobacterial infections or H. pylori. We don't use it commonly for other things because of worse spectrum of toxicities. And that is it. And we have some minutes for questions. Thanks for hanging in there. That was a lot.
No, it was absolutely great. And we have a number of questions, and so we'll get to a few of them here. One of the first ones is, how do you think about interpreting the MIC when you're trying to determine the sensitivity of an antibiotic?
Yeah, so that's a great question. And so I think I would hope, in general, so the way that an MIC is interpreted, like when you see the S or R, the sensitive or resistant on the panel readout from your microlab, they are using national guidelines to give you that interpretation, which a lot of people have worked to actually correlate what we're finding in vitro to a bunch of in vivo data for that specific antibiotic and bacteria combination. It's very specific. You cannot generalize, one MIC to one antibiotic is 0.5 and the other one is 1, and that definitely means that the one works better. That is not necessarily the case. And so they should be giving you an interpretation based on those guidelines, which, says essentially susceptible or resistant. And with almost universal truth, you should be able to hopefully just trust that and not try to get into the weeds of reinterpreting the MICs yourself. Just use, out of the susceptible options, use what you think is the best in terms of toxicity profile or allergy profile of the patient. There are very few situations where that might be different. I will say that the one that comes up very infrequently but very occasionally is a vancomycin MIC for an MRSA isolate, or in a drug-resistant gram-negative organism that has some resistance to ceftriaxone, but not resistance yet to ceftazidime, that might be prone to develop that resistance. Those situations, our microlab has put extra notes on the cultures to let patients, providers know that they might not actually be able to use specific antibiotic, even though it's read as susceptible. My hope is that most labs will do that also, because we really can't expect every provider, every, hospitalist, every primary care doctor, anybody to have memorized what are the situations where you can't just rely on the MIC, or I'm sorry, rely on the interpretation from the microlab. So usually I would just try to not try to parse through those yourself, just try to rely on the susceptible and resistant. And hopefully most microlabs are doing a good job of just annotating in the very few situations where that might not be accurate.
Perfect. I think that's very helpful and a question that comes up a lot. There are a couple questions about anaerobic coverage. And one is, if sometimes we see people who might be put on piperacillin tazobactam or ampicillin sulbactam plus metronidazole. Is there any indication for that kind of double coverage in your eyes?
Really, not really. No. I think if a patient has a concern for breakthrough, there's a very, very low but non-zero risk of resistance to piperacillin tazobactam with Bacteroides. But if I was worried that this patient was going to have a breakthrough infection with Bacteroides or had already had a Bacteroides bacteremia, I would probably use metronidazole in combination with something else. I wouldn't need to use the piperacillin. I would use it with cefepime or something that's less, because there's no reason to have all that double anaerobic coverage. But that's incredibly rare. The other incredibly rare situation is if the patient had both severe C. diff and a bowel perforation, and we were giving IV metronidazole in combination with fidaxomicin or enteral vancomycin, but also needed bowel flora treatment because they've actually perforated their bowel and we're actually worried about peritonitis from bowel flora. But those are very, very rare. As a general rule, there's no indication for double anaerobic activity.
Perfect. Thank you so much, Dr. Johnson. That's all the time we have for questions.